Hello and welcome to week 5 of PUBH 610. Today we will review cost, access, and quality of healthcare in the United States. The learning objectives for this week are to review trends in healthcare costs and factors that led to past cost escalations, to describe regulatory and market approaches to contain costs, and discuss why some regulatory cost containment approaches were unsuccessful, to discuss various dimensions of access to care and describe access indicators and measurement. And we will also review the nature, scope, and dimensions of quality. And lastly, we'll discuss the implications of the ACA for healthcare costs, access, and quality. Cost, access, and quality are the three major aspects of healthcare delivery. These three aspects are intertwined, as expansion of access will increase healthcare expenditures, otherwise known as costs, and the quality of care people receive is a result of cost and access. Cost is an important component of how we evaluate quality. In order for high-quality care to be sustainable, it should be cost-effective. When we discuss costs this week, remember that we are considering both macro-level costs, such as national health expenditures as a proportion of our gross domestic product, and more micro-level costs, such as employer contributions to employee health insurance and out-of-pocket costs to patients when they receive healthcare services. Lastly, this week, we will dig into quality of healthcare and discuss how it's measured and discuss inequality in healthcare. Overall, the interrelated nature of cost, quality, and access is the major reason why attempts to implement universal coverage in the U.S. have failed, and why population health outcomes in the U.S. lag behind many other developed nations despite our high national health expenditures. National health expenditures jumped in the United States during the 1970s after more Americans gained access to health care through Medicaid and Medicare, which was created in 1965. Since the 1970s, the average annual percentage growth in national healthcare spending has declined due to control over payment and utilization through managed care organizations. However, despite this decline, in 2014, the U.S. spent $3 trillion on healthcare, which is 17.5% of the gross domestic product. Experts agree the U.S. spends far too much money on healthcare, and when we compare our health expenditures in the U.S. to those in other countries, we see that the U.S. growth in healthcare spending has outpaced other countries. When we want to reflect on if we're spending too much money on healthcare costs, we use three sources shown here: international comparisons, the rise in private sector health insurance premiums, which triggered the rise in employee coverage through health maintenance organization plans, and the rise in government spending on various public programs. Many factors have led to rising healthcare expenditures. Some of these we've already discussed, such as the use of third party for payment, which can lead to moral hazard, and the reasons why healthcare is an imperfect market that doesn't follow the principles of a free market. But other reasons for the cost escalation are our obsession with technology and our tendency to adopt early and quickly expand our use of expensive new technologies that may not be cost effective. For example, the use of imaging devices, such as MRIs and CAT scans during visits to doctors' offices, more than tripled from 1996 to 2007. It's not a coincidence that during that same time, the Medicare Part B reimbursement for imaging services paid to doctors more than doubled. Once physician reimbursements for these services were reduced, their use declined. Another reason technology is responsible for our escalating costs is the research and development costs which are required. Another reason is that we are living longer and elderly people consume more healthcare than younger people. Healthcare costs for the elderly are 2.6 times more than those for the non-elderly. Lastly, we have a medical model of healthcare delivery in the United States, and rather than fund public health disease prevention programs and facilitate healthier lifestyles, we wait for people to become sick and treat their diseases, which is far more expensive. Here you can see the change in the U.S. population mix between 1970 and 2014 and the projections for 2030. You'll notice that since 1970, the 0 to 24 age group, which is the dark orange, has declined, and the population over the age of 65 has grown. Here are some of the additional reasons for the rising healthcare costs in the United States, such as high administrative costs, our litigious society, which leads to doctors practicing defensive medicine, fraud and abuse in our healthcare system through practices such as upcoding, in which a higher priced service is billed when a lower priced service is provided. The Anti-Kickback Statute of 1987 tried to reduce fraud and abuse in our system by making it illegal to pay an individual or entity for a referral for services to be paid by Medicaid or Medicare. But fraud and abuse still occur and drive up healthcare costs. Lastly, small area variations in price, which are different rates of hospital admissions and surgical procedures among different communities, and the differences are only associated with geographic area. For example, Medicare spending showed that higher rates of inpatient-based care and specialty services were associated with higher costs, but not with improved quality of care, health outcomes, access to care, or satisfaction with care. This variation, which can be as great as twofold, cannot be explained by gender, age, race, health status, or pricing variations. This variation signals significant inefficiencies in our system because they increase cost without improving outcomes. SAVs are not unique to the United States, and they also exist in Canada and Britain, when some patients in some parts of the country are receiving far too much care and in other places not receiving enough. Regulatory approaches to cost containment typically control healthcare supply, prices, and utilization. These supply-side controls are called health planning, as they enable policymakers to limit the number of hospital beds, the diffusion of costly technology. Health planning refers to a government undertaking steps to align and distribute healthcare resources so that the system will achieve the desired health outcomes for all people. But in a system such as the US, where more than half of healthcare financing is in private hands, there is no central administrative agency to monitor the system. Regarding price controls, the most important effort to regulate costs was Medicare converting to a prospective payment system based on diagnostic-related groups. The DRG system significantly reduced inpatient hospital spending, but unfortunately had little impact on total per capita Medicare spending because costs were shifted from inpatient to outpatient. More recently, there have been efforts to modify Medicare payments to better align with quality of care in pay-for-performance methods. However, pay-for-performance has mixed results and needs to be further researched. Competitive cost containment approaches fall into four broad categories listed here. One example of a demand-side incentive is cost sharing, which is a common feature in most health plans. This assumes that if consumers pay out of pocket a larger share of the cost of their health care, they will use less healthcare services because they will only get what they really need. The RAND health experiment, which is one of the most famous studies in health policy research, demonstrated the effects of cost sharing. The main cost control measures under the ACA aim to cut Medicare payments to providers. Another idea was that competition among health plans through the healthcare exchanges would control costs. Unfortunately, many mandates in the ACA actually increased premium costs. But overall, according to the Commonwealth Fund, the reforms under the ACA have contributed to the slowdown in healthcare spending by tightening provider payment rates and providing incentives to reduce costs. Under the ACA, Medicare is projected to spend $1 trillion less by 2020. Access to care refers to a person's ability to obtain healthcare services when needed. Are they affordable, convenient, acceptable, and timely? Access to care is a key determinant of health, along with hereditary and other factors. Access to care is also seen as a benchmark in assessing the effectiveness of a healthcare delivery system and is used to measure if healthcare delivery systems are equitable. Lastly, access to care is linked to quality of care and the use of needed services. The 5 dimensions of access seen here were first described by Pinchansky and Thomas in 1981. I'm sure you can think of your own personal experiences accessing healthcare and reflect on these dimensions. If you work 9 to 5 and the doctor's office closes at 5 p.m., are the services available? And if you didn't have transportation, would you be able to get there? How much would the care cost? Do the healthcare providers speak your language? And were you able to get an appointment in a reasonable time period? Or did you feel comfortable talking to your doctor about your concerns? All of these questions relate to access of care and impact health outcomes. Using conceptual models, access is measured at 3 levels: the individual, the health plan, and the delivery system. At the individual level, access measures include medical services utilization and the patient's assessment of their interaction with the doctor. For example, differences in doctor's visits by race, gender, age, and income. At the health plan level, access is measured by the characteristics of the plan, such as co-payments and deductibles, the plan practices such as wait times, or if you're required to receive a referral for a specialist, and plan quality as measured by the healthcare effectiveness data and information set and patient satisfaction surveys. At the delivery system level, measurement of access takes on an ecological perspective and looks at entire populations rather than individual experiences. For example, systems access indicators include health policies, physician population ratio, and the number of hospital beds per 1,000 population. Here we have a graph from Kaiser Family Foundation showing the percent of uninsured Americans by state in 2017. And you notice that many of the southern states that did not adopt Medicaid expansion have higher rates of uninsured populations and are darker blue. This is a measurement of the current state of access at the delivery system level. And here we have another graph showing the percentage of adults going without care due to cost. This could be a measurement of the current state of access at the health plan level if people in these states have higher co-payments and costs associated with care, and therefore are going without care. But it is likely more reflective of the healthcare delivery system, as many of the same states as the previous slide are dark, and people who are uninsured may avoid care due to cost. Follow the link to go to the U.S. News and World Report Data Explorer, which has some interesting graphics of drivers of good health across the states. Overall, access to health care has increased under the ACA. For example, the proportion of the U.S. population without a regular source of care decreased from 29.8% in 2013 to 26% in 2014, and by 2015, almost 74% of all non-elderly adults reported having a usual source of care. There are also fewer reports of problems with medical bills and financial barriers since the ACA. But as we saw in the last graph, many Americans still do not access health care due to cost, and there are gaps in access. Also, under the ACA, the 10 essential health benefits improved access to preventative services without cost sharing, as it required health plans to cover these 10 essential services. Here are the 10 essential health benefits that insurance plans must cover under the ACA. For a long time, quality of care was conceptualized only as overuse, underuse, or misuse. Look at the facts on the left. Can you identify which is an example of misuse, which is an example of overuse, and which is an example of underuse? The 32,000 people who died from preventable medical errors in a hospital setting is an example of misuse. The 57,000 people who died because they didn't receive appropriate medical care, in most cases because conditions such as high blood pressure or cholesterol are not adequately controlled, is an example of underuse. And the example of the increase in spinal surgeries from 1996 to 2001, even though there wasn't evidence to support these surgeries, is an example of overuse. In 2000, the Institute of Medicine report was published, and it dramatically changed the way we conceptualize quality. It coined the term the quality chasm, which is the gap between what we know and what we do. The IOM defined quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. The IOM identified 6 areas for quality improvement, which are shown here. The vast majority of quality measures address effectiveness and safety. A smaller number examine timeliness and patient-centeredness, and unfortunately very few assess the efficiency or equity of care. The report focuses on services provided by the healthcare delivery system. However, quality may be evaluated from the perspective of individuals and populations or communities, but almost always the emphasis is on desired health outcomes. When desired health outcomes are not achieved, we must examine the processes and structures to identify what is going on and correct problems. There are several different processes that improve quality, such as clinical practice guidelines, cost efficiency, critical pathways, and risk management. Clinical practice guidelines, just as the name implies, are explicit descriptions of which clinical processes should be carried out for which specific condition. The goal here is for clinicians to adopt the best evidence-based practice for a given health condition, and that this will improve outcomes and reduce costs by reducing inefficiencies. However, critics view these guidelines as an administrative mechanism to reduce healthcare utilization. Cost efficiency, also known as cost effectiveness, is an important and contentious method of assessment. A service is cost effective when the benefit received is greater than the cost incurred to provide the service. Cost effectiveness aims to reduce healthcare costs without lowering quality, and in some cases this is possible, such as the introduction of prospective payment systems such as DRGs by Medicare. The resulting earlier discharge of patients made some people concerned, but it was found that processes of care improved in hospitals as a result of DRGs, and mortality rates were unchanged or lower. However, cost-effectiveness research has been questioned, and some would call it unethical. For example, it may not be cost-effective to perform a heart surgery on a 98-year-old. However, should we deny him that care because it's not cost-effective? Critical pathways are care management tools that are interdisciplinary and facilitate care coordination. Interventions include treatments, tests, discharge planning, and patient education. Critical pathways can vary by facility and caregivers, and therefore are difficult to replicate and standardize. But within a facility, the use of a critical pathway can reduce medical errors, improve collaboration, and improve quality of care. Lastly, risk management consists of proactive efforts to prevent adverse events specifically focused on avoiding medical errors and malpractice. Healthcare organizations review their clinical processes for a specific purpose of reducing the risk of malpractice, which can improve quality of care, but it can also lead to practicing defensive medicine, which may result in the overuse of services and raise questions about cost effectiveness. If we're talking about quality of care, we must also discuss the inequality in care that is present in our healthcare system. This paper by Dr. Kalman and the Bronx Health Reach is from 2005, so it's a little old, but unfortunately the racial disparities in care are largely the same today. The study found pervasive segregation of care based on the link between race, ethnicity, and insurance status, resulting in the systematic separation of whites and people of color into different systems of care. We called it medical apartheid. The authors found that Medicaid for the poor pays physicians far less than Medicare for the elderly and disabled for the same exact services. Medicaid also spends more per person per year for whites than it does for people of color. They found that different payment policies contribute to different systems of care. The ACA tried to remedy this gap between reimbursement rates for Medicaid and Medicare, but ultimately a gap remains. Please watch the video posted on Blackboard in which Dr. Sanjay Gupta interviews Dr. Kalman about his research in the Bronx. The ACA established the National Quality Strategy to set national goals to improve the quality of care. The objectives are to make healthcare more accessible, safe, and patient-centered, to address environmental, social, and behavioral influences on health and healthcare, and to make care more affordable. In order to achieve these goals, the ACA included several provisions to improve quality of care, such as programs that link payment to quality outcomes in Medicare, strengthening quality infrastructure, and funding the development of the patient-centered medical home, where care is coordinated and less fragmented. Organizations are now incentivized to provide high-quality care because they don't want to be financially penalized for not meeting quality targets, and they want to benefit from the shared savings generated from implementing the quality measures. Since the ACA has been implemented, the number of medical errors and patient safety concerns have decreased, and the Patient-Centered Outcomes Research Institute was established and is responsible for comparative effectiveness research, which studies health outcomes and the clinical effectiveness and appropriateness of different medical treatments. The goal of PROQUARY is to improve the quality and relevance of evidence available to help patients, caregivers, employers, and clinicians make more informed healthcare decisions. In summary, increasing costs, lack of access, and quality concerns pose the greatest challenges, and a lack of universal coverage negatively affects the health status of uninsured groups. Access to medical care is one of the key determinants of health status, and these issues of cost, access, and quality are complex and interrelated. Don't forget that quality of care is rather subjective and particularly difficult to measure. However, it is receiving growing attention. Quality at micro levels include patient experience with clinical care, interpersonal aspects of care, and quality of life, while macro level quality of care indicators look at mortality rates, life expectancy, and disparities across populations. I hope this week expanded your knowledge of these three important aspects of our healthcare delivery system and prompts you to think more critically about how we can expand access, improve quality, and reduce the cost of care for all Americans. That's it for this week. Please see Blackboard for additional materials.